said they don't want to know the root cause of chronic illness. Dr. Case Means talked about in her medical education, they didn't spend an hour talking about nutrition. And Mr. Butner, you're talking about, trying to design a city for the right food choices, but again, what are those right food choices? I think it's becoming pretty obvious. And I think that's one of the questions I have for, Dr. Patrick. We've known about this for quite some time, right? The food pyramid was a marketing. There's nothing scientific about that. It was a marketing deal. We've gone to seed oils. Again, the problem we have as a consumer is, again, you have all the books out there. You have all these different theories. Who do you believe?
Gene will now come to order. That works. I want to thank all of you for being here today. Every member of this committee is a parent, and most of us, well, some of us are grandparents. I'm a grandparent. Living a long and healthy life is something that is very important to me, and I'm sure to all of our members on this committee. But having more time with our loved ones is only half the issue. What I hope is to focus on today is extending not just our lifespans, but the number of years we live, but also our health spans, the number of years we live free of disease or disability. I'm trying to make sure I have none of those. It's no secret that we're facing significant health issues in our country. Americans are plagued by preventable chronic diseases, cancers, and other illnesses, and these are, not all of them, but many of them are preventable. Heart disease, cancer, diabetes are the leading causes of death and disability in the United States. It's a massive problem. 6 in 10 Americans have at least chronic disease, at least one chronic disease, and 4 in 10 have 2 or more chronic diseases, according to the CDC. Here's the good news. Healthy life choices can mitigate, in some cases, completely prevent these illnesses. And you could, if you start any time in your life, you can change your life. I believe that the American people make smart choices when they have good information. In Florida, we see that ahead of every hurricane season. When families understand the dangers of inaction, they make the decision to do what is best for themselves and their loved ones. With hurricanes, we say that preparedness saves lives, and it does. It's no different for our health. Think about it this way: preparedness happens when education is met with action. Just having the information is not enough. You got to take action with it. Unfortunately, the American people are being underserved in both categories, education and action. Too much of the conversation around health these days is reactive instead of preventive. We spend a lot of time talking about how to deal with health issues and not enough time talking about the simple ways to prevent these illnesses in the first place. Even more frustrating is that there is a huge amount of research out there showing how Americans can live longer, healthier lives, but an inexcusable lack of action to put these best practices in place. That's what today's hearing will be about, turning research into action that improves the health and wellness of Americans so we can all enjoy living longer, healthier lives and spend our senior years enjoying time with family. It's time to put a lot more focus and action on wellness and prevention. As our witnesses here will discuss, it's not too late for anyone, even our seniors, to start making informed choices that lead to healthier, happier, and longer lives. That's why I'm proud to be part of the MAHA caucus here in the Senate. I look forward to working with RFK Jr. and Mehmet Oz to create a healthier country. The issue of longevity is also something our government should be more focused on. When Americans live healthier lives, healthcare costs come down. The chronic diseases I mentioned before are also leading drivers of America's $4.5 trillion in annual healthcare costs, according to the CDC. We're all fiduciaries of the American taxpayers, and when we can do something that helps people live healthier lives while saving taxpayer money, everybody wins. I look forward to an insightful discussion today on how we can advance good research, take action that improves wellness for action seniors today and for generations to come. Now let me turn it over to the ranking member, Senator Gillibrand.
Thank you, Chairman Scott, for calling today's hearing. We all want to live a long and full life. Longevity brings people so many wonderful things like opportunities to spend time with their family, to travel, and to continue to thrive. Ensuring that we remain healthy as we age is our utmost importance. Today, we'll hear from 4 witnesses who represent 4 components of healthy aging: research, nutrition, exercise, and medicine. We all know that we should eat a healthy diet, remain active, seek preventive care, and avoid habits that contribute to disease. As we'll hear from Dr. Nozel, so many Americans do not have access to affordable health care, stable housing, financial security, or even walkable communities. So we need to address some of those impediments and some of those challenges. We also know that these factors, often called social determinants of health, are often key to understanding how we can then allow for people to make those healthier choices. Those structural barriers often make it hard to achieve health at any age. Congress has to do more to ensure that all people are able to meet their basic needs so that they can learn how to optimize their longevity and their health. It's why I've introduced the Strategic Plan for Aging in the last Congress. This bill would provide states with critical funding to transform their infrastructure and build communities that meet the needs of older adults and future generations. It would address everything from housing to healthcare to food insecurity to make sure these systems are able to support our aging population. And I'm proud that my home state of New York is in the process of developing a strategic plan. These are positive steps to helping older adults achieve longevity. We are all aging, which is not in and of itself a disease, but a natural process. And we have a duty to ensure all Americans can age well and age gracefully. I look forward to hearing from today's witnesses.
Thank you, Ranking Member Gillibrand. I'd like to welcome our witnesses here today. Before I introduce our first witness, I'd like to ask each of you to be mindful of our limited time here to get today and keep everyone's opening statements to 5 minutes. First, I'd like to introduce Dr. Rhonda Patrick. Dr. Patrick is a scientist and health educator recognized for her leadership in nutrition, aging, and disease prevention. Dr. Patrick earned her PhD in biomedical science, conducted her graduate research at St. Jude Children's Research Hospital. She completed her postdoctoral fellowship at Children's Hospital Oakland Research Institute and has also conducted research on aging at the Salk Institute for Biological Studies. It is Dr. Patrick's goal to challenge the status quo and encourage the wider public to think about health and longevity using a proactive, preventive approach. As the founder of Found My Fitness, she shares expert, evidence-based insights on aging and disease prevention with her own unique brand of scientific rigor, engaging millions through her website, podcast, and YouTube channel, where she has a combined following of more than 2 million people across the world. Dr. Patrick.
Thank you, Chairman Scott. Yes, my name is Rhonda Patrick. I'm happy to be here today. And is this just an introduction I'm doing, or is this my opening statement?
I'm glad you're here. We're glad you're here.
Thank you.
If you want to do your opening statement.
Yes, okay. All right, so we have to ask ourselves if we can call ourselves the greatest nation in the world, while 70%, nearly 3 out of 4 adults are overweight or obese, while we spend about 18% of our GDP on healthcare, more than any other nation, and yet we rank 55th in life expectancy. Our children are getting type 2 diabetes at unheard of rates. This is not just a health crisis, it is a cultural crisis. Obesity is not inevitable. It is not an act of God. It is something that can be prevented. It is a choice that has been compounded by bad habits over time. It is reinforced by a culture that does not foster good decision-making and self-discipline. And we have created a culture where these difficult truths have become personal attacks, where physicians are afraid to talk about a patient's weight because it's too taboo. If we can't have a conversation about obesity, how can we ever solve the obesity crisis? Obesity is associated with 13 different types of cancers. It takes between 3 to 10 years off of life expectancy. It damages DNA, causes double-stranded breaks to DNA, which is the precursor to oncogenic mutations, and it fundamentally accelerates the aging process. And yet it is the principal difference between our nation and the longest-lived nations. We are overfed but undernourished. So about, I would say, 60% of daily total calories consumed by the average American come from ultra-processed foods. These foods are caloric rich, they are nutrient poor, they do not increase satiety, so people do not get satiated, they continue to overeat, they gain weight. They are cheaper than whole foods, so people are economically incentivized to eat unhealthy, and they activate the dopamine reward pathways in our brain, causing addiction. So this trifecta of no satiety, low cost, and addiction really kind of spiral us into this process of poor health outcomes and runaway healthcare costs. And it's not, overconsumption of calories is actually not the only problem. We are also micronutrient deficient. So the food we eat is supposed to provide us with essential vitamins and minerals that run our entire metabolism. Omega-3, so about 80 to 90% of Americans have low omega-3 levels. We now know that low omega-3 levels have the same mortality risk as smoking. Vitamin D deficiency, easily corrected. Vitamin D gets converted into a steroid hormone that basically runs about 5% of our protein encoding human genome. Everything from immune function to brain function to cancer. Very important, easily corrected. Magnesium, about half the country does not get enough magnesium from their diet. Magnesium is essential for over 300 enzymes in the body, including repairing damage to our DNA. DNA damage is happening every day. It's not something you can see in the mirror. It's not something that you're going to know about on a day-to-day basis, but it is what promotes cancer. So decades later, it rears its ugly head. But the real problem is simpler. We actually need to start thinking about physical inactivity as a disease. We now know that it carries the same mortality risk as smoking, cardiovascular disease, and type 2 diabetes. Yet, when the average American reaches age 50, they lose about 10% of their peak muscle mass. By the time they reach age 70, they're losing about 40% of their peak muscle mass. And this isn't just about looking strong, it's about physical independence, it's about survival. So higher muscle mass is associated with a 30% lower all-cause mortality. Grip strength is actually a better predictor of cardiovascular-related mortality, the #1 killer in the United States, than high blood pressure, and yet nobody talks about it. And strength is also associated with a 42% lower dementia risk. And yet we think of resistance training as an add-on, as a luxury. It is not. It is a fundamental pillar of aging. It increases muscle mass, muscle strength, and bone mineral density. So fractures are a death sentence. Between 20 to 60% of Americans that have a hip fracture die within a year. And yet resistance training can lower fracture risk by 30 to 40%. This is preventable. We have the information, we have the data, we need to take action. And resistance training, exercise, getting the right foods are the most important things that we can do to prevent disease and make a difference in our country. So thank you.
Thank you. Next, I'd like to introduce Dr. Eric Verdin. Dr. Verdin is the President and Chief Executive Officer of the Buck Institute for Research on Aging, the world's only research institution singularly focused on the biology of aging, yielding insights into age-related diseases before they start. Dr. Verdin received his doctorate of medicine from the University of Liège and completed additional clinical and research training at Harvard Medical School. Dr. Verdin has published more than 210 scientific papers and holds more than 15 patents. He's held faculty positions at the University of Brussels, the National Institutes of Health, and the Bacoyer Institute for Medical Research. He's also a professor of medicine at University of California, San Francisco. Dr. Verdin.
Good afternoon, Chair Scott, Ranking Member Gillibrand, and members of the committee. Thank you for the opportunity to speak today. As Chair Scott mentioned, my name is Eric Verdin. I run the Buck Institute for Research on Aging in Northern California. This is the world-leading research organization on the biology of aging. Our mission is to eliminate the threat of chronic diseases by addressing the aging process itself. Over the past century, public health advances and medical breakthroughs have nearly doubled the lifespan. This incredible success has come with a number of challenges. We live longer, but not healthier. The end of our long lives is now characterized by a whole series of debilitating diseases, including Alzheimer's, Parkinson's, heart attacks, strokes, type 2 diabetes, cancer, osteoarthritis, macular degeneration. By the time an American reaches age 65, most have at least one chronic disease of aging, and 70% have two. We call these conditions the chronic diseases of aging. Our current healthcare system is focused on treating these conditions when they occur, not in preventing them in the first place. This approach is expensive, inefficient, and ultimately ineffective. The cost of managing these illnesses is actually staggering. Increasing as our population ages, and places an unsustainable financial and emotional burden on our healthcare system, our citizens, and their families. In the 20th century, we dramatically reduced death from infections, from heart disease, and from cancer, extending life expectancy in the process. But progress is slowing. Even if we cured cancer tomorrow, the average lifespan would increase by less than 3 years. The reason is simple. The aging itself and its associated complications continues unchecked. Aging is the greatest risk factor and the main driver for these chronic diseases of aging. The good news is that we now know from research from the past 20 years that aging can be slowed. And we have preliminary evidence that it can actually be somewhat reverted in some cases, thereby extending healthy lifespan and delaying disease in animal model systems. There is not a single reason why these findings should not apply to humans as well. By focusing on aging and its mechanism, we can compress the period of illness associated with aging so that our later years are spent in good health. The economic and public health benefits of a shift from a reactive healthcare system to a true preventative healthcare based on our understanding of aging are enormous. Studies suggest that delaying aging will generate trillions of dollars in economic gains, reduce medical costs, and increase productivity. Just as vaccines and antibiotics revolutionized medicine in the past, aging science is the next great frontier in preventive healthcare. The science is at a turning point, and as policymakers, you will play a critical role in ensuring that we realize its benefits. Investing in aging research must be a priority. The NIH should increase funding on the molecular pathway of aging with a new emphasis on translating discoveries into human applications. We also need a much greater focus on lifestyle interventions. Nutrition, exercise, sleep, stress management, and social connections. These variables account for more than 90% of our health span and our lifespan and should be an essential part of our health policy and our research. We must also rethink how we allocate healthcare dollars. Right now, we spend trillions on treating diseases after they arise. A shift towards prevention, one that targets aging itself, would be far more productive and effective. The FDA needs clear guidelines for aging-targeted therapies. Biotech and pharma companies are investing in this field, but without a defined regulatory pathway, progress is slowed. And finally, we need stronger public-private collaborations. Translating discoveries into real-world application will require coordinated efforts between industry, government, and regulatory agencies. This is a pivotal moment. The 21st century has the potential to witness one of the most profound medical breakthroughs in history, not just treating age-related diseases, but preventing them. The goal is not just to extend lifespan, but to ensure those extra years are spent in health, dignity, and independence. I applaud the committee for recognizing the urgency of this issue. Aging research is at an inflection point, and with the right policies, we can transform public health for generations to come. I look forward to working with you to make this vision a reality. Thank you.
Thank you, Dr. Verdon. Now, I'd like to recognize Ranking Member Gillibrand to introduce her witness.
Dr. Sarah Nozel is a family medicine physician who practices at a federally qualified health center in the South Bronx. She's also the president-elect of the American Academy of Family Physicians. Thank you for being here, Dr. Nozel.
Thank you so much. Chairman Scott, Ranking Member Gillibrand, and members of the committee, thank you for the opportunity to testify today. My name is Sarah Nozel, and I'm a practicing family physician in the South Bronx. As the president-elect of the American Academy of Family Physicians, I'm honored to be here today representing more than 130,000 physicians and student members of the AAFP. I currently work at the Institute for Family Health, a network of federally qualified health centers with more than 27 locations across New York State. I am proud to be a family physician. In my office, I have the honor and privilege of taking care of not just patients, but families and communities. Last month, Chairman Scott laid out his priorities, which identified 4 aspects of someone to be well: having their physical health, financial security, a safe community to live in, and family and community support. Each of these are rooted in the very fundamentals of family medicine. I have practiced for more than 2 decades in a community that ranks last for health outcomes in New York. My personal patient panel approaches nearly 90% Medicaid beneficiaries. A typical patient of mine presents with cane in hand, living with HIV, diabetes, hypertension, and chronic kidney disease. Patient-tailored counseling on diet and exercise is something I do in every visit. Unfortunately, while I talk about the importance of eating healthy, whole foods, the reality is most of them are often out of reach financially or otherwise inaccessible to most of my patients. This is only one of the health-related social needs that impact them. A lack of stable housing, reliable transportation, safe places to exercise, and financial security also make it difficult, if not impossible, for my patients to afford medications and even make it to medical visits. Research has consistently shown that health-related social needs can worsen health outcomes. On more than one occasion, when I've asked a patient why they were not taking their insulin as I directed, I would learn that they did not have electricity in their apartments for the last few weeks when they fell behind on rent. Patients at our rural clinic have been known to walk long distances along roadsides without walkways. At our urban clinic, patients with walkers face 4 flights of stairs at the subway. Many of my patients experience food insecurity, for which the USDA SNAP program is a lifeline. Congress can strengthen to ensure it better serves those in need. However, that alone will not solve my patients' challenges. While diet and exercise are important to health and wellness, we cannot ignore that many communities are designed with them out of reach. Food and exercise can only be medicine if they are easily accessible. As a family physician, I recommend a healthy diet and working out. But it is up to you, our elected leaders, to ensure the resources are in place to fill that prescription. Congress must support promising, innovative policies to address health-related social needs, such as expanding Medicaid coverage for reimbursable services. For example, some states have used existing Medicaid authorities to provide medically tailored meals to whole households, not just the eligible beneficiary. This recognizes that a food-insecure parent will often give their meal to a hungry child rather than feed themselves. Many of my young or middle-aged patients are caregivers for both young children and older relatives. Any reforms that affect their healthcare coverage may impact their employment, their ability to help their mother make rent, to take their grandma to the laundromat, or contribute to any productive, meaningful way in their community. Insurance does not help patients if there is no access to care. Community health centers provide care to those in underserved areas and are often the only accessible care setting for many. CHCs have a significant economic impact and are incredibly efficient in terms of healthcare spending. Further, many CHCs are training the next generation of family physicians through HRSA's Teaching Health Center Graduate Medical Education Program. Thanks to THC GME, our system has multiple family medicine residency programs. THCs have the highest success rate of any program for retaining residents in communities of need. Unfortunately, CHCs and THC GME rely on a patchwork of inconsistent, temporary federal funding. Right now, both programs are only funded through March 31st. To support and improve the quality of life for all patients and in all communities, I urge Congress to make long-term funding for CHCs and the THC GME a priority. In closing, thank you again for this opportunity to testify, and I look forward to answering your questions.
Thank you. We do have one more witness coming, but he's had some travel issues, so he'll be here in just a few minutes. So we'll go ahead and go to questions, and I'll start. First off, thanks all of you for being here. Thanks for caring. Dr. Patrick, our healthcare system is broken. It's reactive, not preventative. How do we get more longevity-focused care into mainstream medicine, and what's standing in the way?
Well, I think that the most important thing that we can do right now for longevity medicine is actually move more. And I think that the federal exercise guidelines are sort of out of date, to be honest. We don't focus at all on resistance training. It says 2 days a week. What does that mean? I mean, to be honest, people might just start doing some bicep curls, and I mean, there's not information there. You need to give people specific information, actionable information. I think resistance training, okay, well, you can do, 7 or 8 15-minute workouts throughout the week, and that's as good as doing 3 45-minute workouts in terms of gaining muscle mass and strength. So giving some more specifics in terms of like types of exercise, also compound lifts. Like you wanna basically make people be physically independent. So you don't want bicep curls. You want people to be doing squats, or you want them to be doing rows or deadlifts, things that are multi-joint, right? I also think exercise snacks is a big one. So there's nothing in the guidelines about how people can get exercise benefits by doing these short bursts of physical activity. Tons of research coming out on this. I mean, we're talking, a recent study just showed that doing 10 bodyweight squats every 45 minutes over a 7.5-hour work week was better at improving blood sugar regulation than a 30-minute walk. I mean, that's like 2.5 minutes a day. There's also tons of evidence coming out on these unstructured exercise snacks. And that's also something that can be recommended. So these are the kind of things that you take the stairs instead of the elevator, or you walk briskly instead of, taking a car to work, And there have been studies showing that people wearing these accelerometers are able to reduce their cancer mortality by 40%, their cardiovascular related mortality by 50% if they're doing 9 minutes a day of these unstructured snacks, where they're just basically taking advantage of everyday situations to get physically active. It doesn't cost money to do bodyweight squats. You don't have to have a gym membership. So I think that's one important way that I think information can be improved and more targeted.
Thanks. Dr. Verdon, what's the most important breakthrough in aging research that we should be paying attention to, and how can we use it to actually help people live healthier, longer lives?
There's been an explosion of understanding of the biology of aging, and in particular, the identification of what we call molecular targets. We now understand that targeting unique molecules can actually have profound effect on the whole aging process and on the associated disease. I also want to expand on what Rhonda just talked about, this idea of lifestyle factors. We talked about exercise, but there's a group of lifestyle factors that we all know about: nutrition, physical activity, sleep, human connections, that are really the critical determinant of your longevity. Actually, more than 90% of our longevity for most people is determined by the way we live. What's really important is to know also each of these variables are stackable. That is, if you are eating well, you're going to live longer, but if you actually exercise on top of it, you're going to live even longer. And if you have good human connections, you're going to live longer. Today, most of us in this country could expect to live to 90 to 95 in good health if we were to do everything right. So that's today. And there are communities within the US who live today close to 90 years old on average. And I can guarantee that not all of these communities are actually optimized in terms of doing everything. Right now, as as someone who studies aging, I'm struck by the divide, the lack of knowledge of some of the things that we know are conducive to good health are not actually implemented. And I want to add one last point about exercise. A 15-minute walk in the morning and at night will lead to a reduction of heart attack, stroke, cancer, all of these chronic diseases of aging by 40%. That's 30 minutes of walk every day. And I defy anyone, no matter what their lifestyle is, to tell me that they do not have the time to walk 15 minutes in the morning and 15 minutes at night. This is the type of information that people are not aware of, and it could have profound effect on the health of our population. So I'm really passionate about lifestyle. Next will be, of course, the additional interventions that the research is pushing forward. But for me, the foundation has to be these lifestyle factors. Drugs that target the aging process will come in the future. We're working on them. There are some really promising leads, but they should not be a replacement for reestablishing a healthy lifestyle in ourselves and the population at large.
Thanks. Let me now turn over for questions to Ranking Member Gillibrand.
Thank you, Mr. Chairman. Dr. Nozzle, Nozzle, how do you say it?
You said it perfectly from the
Nozzle.
beginning.
Okay.
Knows all, but quickly.
Knows all. Got it. Knows all. Love that. So sometimes there's barriers to the things that we know are needed for longevity. Healthy eating is one. Obviously, there's barriers to affordability. There's barriers like food deserts when it's not easy to get to a grocery store. Sometimes it's just mobility. If you're in a fifth store building and you're not very mobile and you can't walk to the grocery store and you don't have a car and it's hard to get on the bus, the many barriers. But one of the barriers I want to talk about with you is the nutritious aspect of it. A lot of people don't even know what's nutritious. Our doctors don't really study it in medicine. It's not common knowledge in culture. It's not well known what's nutritious and what's good for you. So one of the things that you talked about in your testimony, a 4-year nationwide pilot program through Medicare to provide medically tailored meals to eligible Medicare beneficiaries with diet-impacted conditions. Now, this is innovation. We know that a medically tailored meal for somebody with diabetes is going to be extremely healthy for them. It'll have a lot more fruits and vegetables in it. It will have whole grains. It will have lean proteins. It will have no processed foods. So medically tailored meals really is pretty powerful. Can you talk about that a little bit? And how could we implement it as just one of the barriers?
Thank you so much. So as I said, I'm a practicing family doc. I was seeing patients this week, and I actually saw a patient who I really wish this was one of the services I was able to prescribe her as part of her Medicare coverage. She gave me permission to share her story. This is a woman I've taken care of for quite a number of years and has done a really great job at being physically active to the best of her ability. She uses a rolling walker with chair, and she has really well controlled her diabetes, had it as well as it can be controlled, reduced her risk of complications, and then came in this week and saw me, and her diabetes was fully uncontrolled. And I asked her what was going on, and she said her apartment had moved. And so previously where she lived, she knew where the local soup kitchen was and the food pantry. She used her SNAP benefits, as I work with my patients to use their SNAP benefits for fruits and vegetables, use the other resources which are more likely to give you more processed foods or carbohydrates, get those other foods there, but save your benefits and you can get some extra incentives. But this is really a patient who cannot find in her community where she is the resources to have the healthy meal that she needs, that it will be part of her remaining well and full. And the idea that I could have prescribed her a appropriate low-calorie, diabetic diet full of whole, plant-forward, protein and foods would be the complete difference in her entire life. I agree with the speakers before me that your ability to move and your ability to eat healthy and have access to those nutritious food resources, this could be groundbreaking and life-changing for our older adults. And this can be done right through our health centers, right through our community health centers that are in the depths of the communities where we can do this for a whole family and prevent the outcomes. I don't need to take care of people in a state of disease. We are ready and willing and able in our health centers to care for communities that we know their risk is greater, but our ability to provide these medically tailored meals will change both cost and outcomes in that community.
So along the lines of impediments to access to nutritious meals, we have SNAP benefits, and SNAP benefits, you go to the grocery store and buy your groceries and cook whatever you want. But for older people who aren't cooking as much anymore, again, who can't carry the 2 bags of groceries of all that fruits and vegetables and the whole grains that they're going to then cook appropriately to eat, what do you think about the idea of being able to use SNAP benefits for congregate meals or for organizations like Meals on Wheels that deliver hot meals? Like, is that a way to get over some of these barriers to the nutritious or medically tailored meals that people need?
It would be tremendous if we could both increase funding for SNAP benefits. I can tell you they don't meet the needs even right now, but the kinds of creative programs I know that we've done where I live, where we have been able to increase funding for fruits and vegetables. But my elderly patients are often only eating a hot meal if a family member comes to help care for them and cook for them. They often have nutritional deficiencies because they are in fact eating things that are either come in a bag or a box, which are my top lists of things I tell patients to try to not eat. But that really isn't feasible or possible for them. It would be astounding if they could actually use those benefits and have that kind of food delivered at their home. It would be life-changing.
Thank you. Now I'd like to recognize our last witness. I guess she had some travel issues, so we're glad you made it. Dan Butner. Dan is an explorer, National Geographic Fellow, Emmy Award-winning journalist and producer, New York Times bestselling author and founder of Blue Zones. The term Blue Zones was first coined by Dan in 2004 and refers to areas with high concentrations of centenarians, individuals who live to be over 100 years old. His team uses research to highlight and promote specific lifestyle habits that are tied to extended longevity and vitality. Thanks for being here, and we're looking forward to hearing your presentation.
Honored to be here. Well, my goal here over the next...
Yeah, push the red button.
Yes, my goal over the next 4 minutes and 54 seconds is to convince you that most of what we think works for healthy aging and longevity is either ineffective or just plain wrong. I know most of you know these statistics, but we're spending $4.9 trillion on healthcare per year. About 85% of that money is spent on people with chronic conditions. Most of them are avoidable chronic conditions. Another $300 billion on exercise and diet programs, and then another $42 billion on anti-aging industry that has failed to produce even one pill, supplement, or intervention that's been shown to stop, reverse, or slow aging. So if that doesn't work, what does? 20 years ago, working with National Geographic and a team of demographers, we found 5 areas in the world where people are living statistically longest. Something called the Danish Twin Study established that only about 15% of how long we live is dictated by our genes. 85% is something else, and we reasoned we'd find that something else among these 5 populations who are living about 10 years longer at middle age, our age. The reason they're living 10 years longer is because they're avoiding the diseases that foreshorten Americans' lives and are kind of bankrupting us in many ways. What are they doing? Well, none of them are dieting or exercising or running down to Latin America for stem cell treatments. Every time they go to work or a friend's house or out to eat, it occasions a walk. They're getting 8,000 to 10,000 steps per day mindlessly. The cheapest and most accessible foods for them are peasant foods. They're whole grains, they're tubers. The cornerstone of every longevity diet in the world is beans. They're eating about a cup of beans a day. They're not spending time on Facebook. Instead, they're spending time in face-to-face conversations, living in extended families, connecting with their neighbors. They have vocabulary for purpose. Now, there's an idea, purpose. We know that people who have a sense of purpose live about 8 years longer than people who are rudderless. They manifest their purpose usually in family, but also with religion. We know people who show up to church or temple or mosque live about 4 years longer than people who don't show up at all. So taking this insight that where people are living the longest, it's not because they try, it's not because they pursue longevity. We tend to think that health is the result of a pursuit in this country. Actually, it ensues. It's the result of an environment that makes a healthy choice the easy choice. We're not relying on poor mothers to make the right choice and then sending them out into an environment where 97 out of 100 food choices are bad. About 15 years ago, working with AARP and the University of Minnesota, we set out to manufacture Blue Zones by working with municipal governments where you can get policy done to help them decide on policies that favor healthy food over junk food and junk food marketing, to favor the human being over the motorist, to favor the non-smoker over the smoker, and to certify all the restaurants, grocery stores, workplace, schools, and churches who agree to optimize their designs and their policies so that people are nudged into moving more, eating better, and socializing more. The proof is in the pudding. Our very first town, Albert Lea, Minnesota, we saw a 30% drop in healthcare costs among city workers. That was in 2009. In the beach cities of California, we saw about a 25% drop in obesity in the 10 years we were there. And in Fort Worth, Texas, they themselves reported about $250 million in healthcare cost savings after the 5 years we were there. We succeeded not because we came in telling people what to do, came in with an agenda. We simply came in with policy options and place options that made the healthy choice the easy choice. We set Americans up for success. Right now, our food environment and our built environment sets people up for failure. We have about 25 times more fast food restaurants than we did in 1980 when we had a third the rate of obesity that we have right now. So the big idea I'd ask you to think about is shifting the focus from changing people's behavior and individual responsibility and setting Americans up for success by designing our cities so the healthy choice is not only the easy choice, but the unavoidable choice.
Thank you. Yeah, I live in Naples, Florida, and they're working.
That's right. We have Blue Zone City in Naples and Jacksonville, Florida. I salute them.
They're doing a good job. Let me turn it over now to Senator Johnson.
Hey, Mr. Chairman. Very good hearing, very interesting testimony. I held an event end of September with RFK Jr., with Dr. Casey Means, who'd written a book that interested me, Good Energy, talking about metabolic health. Awful lot of the testimony here relates to that in some way, shape, or form. I think two of the most significant parts of that testimony, Dr. Chris Palmer, he's a psychiatrist that does a lot of work in terms of nutrition as it relates to mental health issues, said they don't want to know the root cause of chronic illness. Dr. Casey Means talked about in her medical education, they didn't spend an hour talking about nutrition. And Mr. Butner, you're talking about, trying to design a city for the right food choices, but again, what are those right food choices? I think it's becoming pretty obvious. And I think that's one of the questions I have for, Dr. Patrick. I mean, we've known about this for quite some time, right? The food pyramid was a marketing. There's nothing scientific about that. It was a marketing deal. We've gone to seed oils. Again, the problem we have as a consumer is, again, you have all the books out there. You have all these different theories. Who do you believe? It's a very confusing thing, and unless you just go completely simple, all whole foods, no ultra-processed food, try and approach it that way. But Dr. Patrick, just kind of comment on that.
Well, I do think that going whole foods and trying to reduce your ultra-processed foods as much as possible is the way to go. And I think we have a lot more information now than we did, 30, 40 years ago. We know that these ultra-processed foods are not causing satiety. We know that they're activating these addictive reward pathways in our brain. So I think that information is a little more in depth. But I also think that some of the information on why do we eat? Okay, if we have nutrition in primary and secondary school, definitely medical school, you're right. One class in nutrition, it's absurd, right? If we can start educating at an early age children why they eat, what are they supposed to get from their food? Why do you want to eat leafy greens? Magnesium's there. What does magnesium do? What happens if you don't get magnesium? What is cancer? There's even some data out of Japan. They have that program in Japan where they have in primary schools nutrition education, and they've shown longitudinal studies that people that were educated with nutrition in childhood are much more likely to eat healthy, nutritious later in life.
Part of the problem is just our medical education, our medical establishment. They call it Rockefeller medicine, all based on pharmaceuticals. And it's awful appealing. All we have to do is get a shot, or all we have to do is take a pill, and we're going to be well, when we think probably the exact opposite is true. 85% of our $4.9 trillion spend is on chronic illness. It's about preventing that chronic illness. Dr. Verdon, you talked about the basics, right? Nutrition, exercise, and not necessarily, and then all that is, there's all kinds of different opinions on the right type of exercise. But being active makes sense. Getting good sleep, stress management. All those things make perfect sense. How do we break through? How do we re-educate our doctors? How do we re-educate our public policy here? One thing we could probably do is with our SNAP program, not allow certain foods to be purchased, the really highly ultra-processed, the ones that we really are pretty convinced are not good for you. That would be a good switch, wouldn't it? Dr. Verdon.
Yep. Thank you for the question. I think, first, let me completely agree with you on the idea that the foundation has to be there. The lifestyle factors and the drugs should only come on top, or in a subset of the population that is an increased risk of accelerated aging. That being said, there is something that is happening in the aging field, which I think is going to allow us to work through the noise that you described. Which diet? Paleo diet, ketogenic diet, Atkins. I mean, there's proliferation. People are completely confused. The same about exercise. What are you supposed to do? Is it strength training? Is it yoga? Is it endurance, aerobic, anaerobic? So people essentially throw up their arms in the sky and say, I don't know what to do. The same about sleep. Well, how much should you sleep? What is optimal, and so on. So the whole field of aging right now is in the process of developing what we call these biomarkers of aging, which allow us to measure and to predict the effect of interventions in the long term. So instead of doing a clinical trial, well, you would take a group and have some exercise do strength training, another one do flexibility, and follow them for 30 years to see what happened to them. These novel markers allow us, within a much shorter period, within 1 year, to actually detect a signature. And so there is the promise that developing these tools have been developed, they do exist. And I think we need support to be able to actually test these interventions against one another so that we can actually make the best prediction to people in terms of what is really the optimal way to actually live and to optimize your health. That's where the field is. Again, there's a bottleneck in terms of the funding. These are not cheap studies, but they could have massive implications in terms of public policy recommendations, in terms of what is the optimal way to exercise. I mentioned the point of walking 30 minutes a day. That's already good. It's a 40% reduction. Can we get to an 80% reduction by adding another modality? To what degree are these interventions going to be individual? And so that's a whole other field, a whole other area that the field is studying.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Johnson. Senator Houston.
Thank you, Mr. Chairman. Appreciate the testimony and the thoughts, the conversation. I listen. You can read. It's exercise, it's diet, it's lifestyle choices. If we just made better decisions and were active on those things, we would drive down costs. We would improve quality of life. I heard a lot of talk about longevity. It's not just the number of years; it's the quality of those years that also are almost immeasurable in terms of their value, in terms of your productivity, your joy, your ability to contribute to your family, to your community, if you have those things. And I was also thinking, when you were talking about the access to food, I was also thinking about when you live in a high crime neighborhood, how much harder it also is to be active and to live a healthier life. So I want to ask any of you that have a thought on this, what about this? Our technologies. They seem to be driving isolation and idleness. And as we look at the difficulty we've had as Americans of getting healthier, even though we know all of these things, is there any evidence that you've seen about how our technology is driving isolation or idleness that would affect our health in a negative way versus a positive way? I'm just interested if any of you have thoughts on that.
I have thoughts on the opposite. I mean, so most of us have an Apple Watch or a Fitbit or some sort of wearable device where we can measure our heart rate, we can resting heart rate, or during exercise, a lot of different health parameters. And yet, I think there's a lot of regulations there that don't allow those devices to help give us medical advice. I mean, we have like AI coming out with this. I mean, AI is now being shown to be as good as or better at predicting, disease and illness and looking at all the variables that contribute to that than physicians are. And yet we can't use that information, that health information, for anything. And it seems like it's something that would be very useful for physicians.
Let me challenge you a bit on that. I agree that those things are valuable. I'm not sure that most of us have those things, though. I read in the last couple of years that the average prisoner spends more time outside a day than the average child. Mm-hmm. And I'm just wondering, when you read things like that and you see the amount of the way that social media is affecting particularly young people and that fewer of them are participating in sports, it seems like from the very beginning that we are getting children off to the wrong start as it relates to this. So I see some heads nodding. Others won't have thoughts on that.
As a family physician, I take care of people in pregnancy, newborns, small children. I get to see great-grandparents and the entire family. I think it's an interesting perspective across technology. I'm also the Chief Medical Information Officer at my organization, so overseeing the rollout of our electronic health record and patient portals in English and in Spanish. And so I am right with you. I really worry about my young people in school. When I'm seeing the kids in my practice, I find out what sports they're doing, how much physical activity is in their after-school activity, how often do they have recess. And we know, particularly for young people, and it's a little different for adults about obesity and weight, but for young people, it really, really matters, that activity level that they're doing. And we have models where schools will not have cell phones during the school day, and you'll get rid of your cell phone at the start of the day and you'll get it back later. But I'm not seeing paired with that the kind of investment in making sure we have that funding and education, the teaching staff, and the supervision and expertise to make that physical activity possible there. And that is a wonderful place for prevention. But I want to come to the other part of technology for our older adults. Our rural communities that don't have broadband access, that can't communicate or take advantage of things like telehealth, which are critical when we're following up complex medical issues or preventing falls and trying to really make sure we keep our older adults safe, that it's actually really critical, not only that we have infrastructure that makes access possible, but our isolated older adults and helping and teaching and finding ways both to connect with your physician and with your community, that there's worthy investment there as well.
Yeah, no doubt we made a lot of progress on telehealth and allowing particularly for LD. Others thought? Yeah.
Maybe if I can add something. As a parent, I clearly have seen, and I think all of us who have children have seen the effect of portables on social isolation and physical inactivity. So I do not know, as a scientist working on aging, how to solve this problem. Clearly, there are other countries who have instaured a number of regulations that limit the use of these portables and iPhones and so on by younger individuals who are obviously more vulnerable. And one thing to note is that these are the formative years where critical habits are formed that will last a lifetime. Just wanted to amplify also the point about wearables. Wearables are, I agree with you, today are the remit of a subset of the population that is generally more well-to-do and able to afford it and more interested in its health. I can see the day changing, though, where wearables are going to be part of the tools used by physicians, especially in areas that are remote, in combination with telemedicine for increasing the health in those populations that might be more isolated and not have access to everyday physicians. So the wearable technologies are rapidly accelerating. They are actually, I predict that within the next 5 years, they will be valuable, recognized medical tools in terms of assessing your risks for chronic disease, simply by measuring your movements, looking at your blood sugar, looking at a whole series of variables that I see under your blood pressure and so on. So I think they will become important tools, and with their democratization, we can expect the prices to go down and the value to go up. So I think this is something, if I were a regulator, that I would keep my eyes on as a potential changing factor in the landscape of medicine.
Thank you, Chairman Scott.
Thanks. Senator Justice.
First of all, to our panel and our great witnesses that have come, I didn't have the opportunity to hear you, but I'm sure that we're all singing from the choir. That's all there is to it. You know, I've got to say just this. You know, I'm from West Virginia, and West Virginia has surely got some really tough issues going on. To say the very least, we're the third oldest state in the country. You know, we have a life expectancy of 72.8 years, which is the second lowest. 20% of our folks in West Virginia are 65 and older. You know, we do have affordable housing in West Virginia, and that helps a bunch. But we've got risk factors like you can't imagine, whether they be social isolation or the risk of falls. You know, they could very well be food insecurity, the lack of broadband, transportation issues or medical care issues, and obesity. Obesity, absolutely the worst of the worst. Now, I don't look at by any stretch of the imagination, but I'm trying real hard. And between Baby Dog and I, together, we continue to try real hard. I've lost 55 pounds, and I'm really proud of that, and I've got a long ways to go. Now, Baby Dog isn't subscribing to the same theory that I'm subscribing to. But for those of you that know her, she's a little brown 62-pound watermelon. And she's a little bulldog, and she absolutely loves everybody. But let me just tell you just this. In West Virginia, we do have some things that are going on that are really, really neat stuff. We have the fact that we're a community, and it is so important, absolutely, from the standpoint of family and community. It's so important to our seniors. I just think about this beautiful little girl that's here and everything, and if you could tell me her name, please. Addison? Well, Addison, you are absolutely spectacularly beautiful. And I will promise you, if you'll look up online or whatever, Baby Dog, and look up and just know how much she would love you too. But I tell everyone, and I tell you this just speaking from my heart, I tell you that in many ways, we're here for Addison. Not only are we here for all those of our seniors, all those of our aging, but we're here for Addison because some way, somehow, we've got to change the path of what we're doing today. For that reason, and I don't want this to be such a political issue, but for that reason, that's why I will vote for RFK Jr., because I believe he is at least trying to bring more awareness to all of us. In all honesty, there's so many in my state that need help in every single way. But more than anything, we need knowledge. We need absolutely us to step up. I'll never forget my dad. I'll never forget him ever saying just this. He was trying to figure out where to build a road. And really and truly, he kept listening to engineers all around him. And finally, the lead engineer's name was Kirby Bragg. And he looked at Kirby and said, Kirby, I don't know what the right answer is, but this dadgum well ain't it. Now, if you just think about just that, what we're doing in America today isn't it. That's all there is to it. And we got to do better. And we got to do better for all of us. For myself, believe it or not, for Baby Dog, but more than anything, for Addison. So Addison, thank you for being here, and thank you so much, Mr. Chairman. I'll yield back to you.
Thank you, Senator. Senator Moody.
Thank you, Senator Scott. I agree with you, Senator Justice. I think we're all sitting up here thinking that we can do better, especially with us senators who sit around a lot. I am only 3 weeks into this tenure, and I am noticing that we sit around a lot. So thank you for being here today. Thank you, Chairman Scott and Ranking Member Gillibrand, for holding this important hearing. I think it's important not just for those of us that are learning more about it on the Aging Committee, but those who may be watching and sharing this information around the country. I agree with Senator Justice. Becoming more aware and making sure that others within our states are aware is an incredible first step to making America healthy again. And so thank you for taking the time to be here. I know it isn't always easy to break away from a practice or travel from another state across the country. I really appreciate it. I know some of you are residents. I am the newest senator from Florida. I know some of you are my constituents, so I'm grateful. One of the things that I think our longstanding reactive approach to healthcare means is we spend a lot more money than we probably need to. And I was most fascinated by your work, Mr. Butner. I've actually watched some of the documentaries that you've helped on. In fact, I've recommended my own parents watch those. And I'm fascinated. I'm from a state that is growing exponentially, and there are many new communities being built. There's also those that are going back and trying to readdress how they might rethink their existing communities. And I was really taken with some of the statistics that you included within your written testimony, and some of the places that you've worked with reported annual savings. And so cities reported not just a drop in their physical BMI, but an actual drop in cost to their cities. I think it was in Minnesota, you saw a town that saved 30% of their city worker healthcare costs since they started. I was just wondering, in terms of existing communities that are trying to go back and reconfigure, or new ones that you're working with to kind of build a city to highlight health and community and healthier options. Have you done a study that shows how much might be saved versus what the input of cost to a community or city would be?
I can give you some benchmarks. So if you, not working? Oh, did I turn it off? So if you drop the BMI or the obesity rate in a city of 1 million people, it saves about 19,000 heart attacks over time. The average heart attack costs about $120,000. So you don't have to have a big movement to make a big difference. But essentially what I'm pitching to all you guys is the notion that we tend to think in silver bullets. There's going to be this one magical intervention that's going to save us. Meanwhile, we're surrounded by what I call silver buckshot, these small nudges and defaults. And in all due respect to the federal government, it's a slow-moving tanker. It's hard to move. But city governments, municipal governments, they can move in a hurry. A mayor and a city council in coordination with the business community, they can get a lot done. And simple things, and by the way, we've done this in Naples, Florida, and we're doing it in Jacksonville, something called a complete streets policy. Do you know you can raise the physical activity level of an entire city by 20% by just building streets? So they invite pedestrians, they invite people to socialize, they invite cyclists instead of just cars. That doesn't cost any extra money. Once every 7 years, a street needs to be redone, and when you redo that street, you can just as easily build it for humans and cars rather than just cars. So it's seeing clearly. We know there's a clear correlation between the number of fast food restaurant permits and the obesity rate of a city. If you live in a neighborhood with more than 7 fast food restaurants within a half mile of your home, you're about 35% more likely to be obese than if there are fewer than 3s. In the hands of a city council member, they may decide, well, our children's health is more important than another burger joint, and make the changes appropriately. Billboard advertising. We know that 2 identical neighborhoods, and one neighborhood has billboard advertising, the other one doesn't. The neighborhood with billboard advertising has about 15% higher BMI. So what we try to do is, rather than telling cities what to do, we show them the evidence. We give them about 30 different policies in each of smoking, built environment, and food, things that cost them nothing. And we ask them, would this be effective for you? Would this be feasible for you? And if they say so, then we help them get it done. The wrong thing to do is to come in and say there's a silver bullet. The wrong thing to do is to come in and tell people what to do. But when you show them the evidence, America's smart. There's a lot of very smart mayors and city council people who are tired of seeing their children grow up overweight and tired of seeing their neighbors die prematurely of heart disease and type 2 diabetes. And this is something we can act on right now. And I guess the pitch for federal government is to think about empowering, designing cities for health, rather than continue to look for just the silver bullet.
Thank you, Chairman.
Thank you, Senator. Mr. Butler, we hear a lot about diet and exercise, but you said social connections and purpose are just as important. What can we do without more government spending to encourage stronger communities and healthier lifestyles?
My name is Butner. This is a small detail for the congressional.
I started that, I'm sorry.
Well,
My fault. I own that. I apologize.
what's that?
I said I started that. I apologize.
Oh,
I
no,
own
no
it.
problem. You guys are important. I'm like, well, believe it or not, it is encouraging people to eat at home. Every time we go out to eat, we consume about 300 more calories than we would if we ate at home, and those calories are going to be more laden with sodium, ultra-processed food, and sugar. You can control the calories when you live at home. And we think about educating people. One of my fellow testifiers here had a very good point about teaching children how to cook at home. I know it sounds so hard. I quote from, for National Geographic, I studied a place in Finland called North Karelia. Had the highest rate of cardiovascular disease in the world in 1972. They brought it down by 50%. How did they do it? They did it by changing the environment, making healthy choices easier. And one of those was using church basements to teach mothers how to cook with plants rather than just with meat. And that's an approach that works. And once again, you know, if you take a person, a couch potato who is getting zero physical activity and get them to walk 20 minutes a day, you raise their life expectancy by 3 years. There's no pill, no pharmaceutical in the world that'll raise life expectancy by 3 years. But if you just get people to go from 0 to 20 minutes, we can achieve that by designing our streets and our sidewalks so it's easy for people to go to the grocery stores, easy for people to pick up their coffee, easy for kids to walk to school. It's a very simple solution. It's within our grasp, and it could potentially cost nothing.
I think. Now we'll turn over to Senator Alson-Brooks. By the way, I have to go to a budget hearing, so I'll turn it over to Senator Mooney. And I think you had some more, Senator Gillibrand. Thank each of you for being here, and I love what you're doing.
All right, thank you so much, Mr. Chair and Ranking Member for hosting this important hearing today, and thank you so much as well to our witnesses who have been here. Advancing research on healthy aging is key to helping seniors live longer lives. And Congress must ensure, I believe, that we take action to improve the quality of life for our seniors. So my first question is for Dr. Verdin. As someone who's worked at NIH and continues to engage in aging-related research, the question is, would you speak to the role of the National Institutes on Aging in advancing research on longevity and health span?
Thank you, Senator. I came to this country 42 years ago with a suitcase and an MD degree from Belgium. And I was attracted at that time by what I knew about the NIH and the vision and the biomedical research enterprise that had been created in this country. And I must say that I never looked back one day. Became an American citizen, made this country my home, and still at this point directing a whole institute focused on the biology of aging is a dream job. I think the NIH has been instrumental in creating what has been called the crown jewel of the American government, and frankly, the crown jewel of all biomedical research organizations in the world. The U.S., thanks to the work and the support of the NIH, has created the best biomedical research institute. Remarkably, every dollar that is being invested in the NIH yields $2 of economic output, which is a remarkable outcome for our society. This has yielded countless cures. It has put millions of jobs, created a whole new industry, the whole biotechnology industry, and has given the U.S. a leadership position in the world. We still attract the very best to come and do research and conduct their careers here. So I think from a personal point of view, but also for the country, I think the output from the investment of Congress in the NIH has been nothing short of remarkable.
And I could not disagree with you, Dr. Burden. I agree, especially your characterization that it's a crown jewel. I think it's also very important to aging research and to cures. So would you say that there, right now, NIH, as you may know, is subject to a number of cuts that have been proposed? And would you say that cuts to NIH funding threaten the progress that we have made in research on the aging brain, on Alzheimer's disease, and on dementia research?
Dramatically so. I do worry about the institute that I direct, and I worry about this leadership position that we are in right now. It's a comfortable position. We're leading by far every other country in the world. China is making great strides in terms of really pushing into biology. Recent JP Morgan meeting in San Francisco about a month ago saw very strong presence from China. And I think there's a danger that we're going to be relinquishing this leadership position, that we're going to be missing on new opportunities to develop new treatments, especially in the field of aging, and that we are going to be basically losing a lot of jobs. There's no way around this. From a personal point of view, in terms of the institute that I direct, if these cuts actually come to effect the way we have seen them, we'll have layoffs, we will have a difficult time, a difficult road ahead. And I think this will be replicated across the whole country, red and blue states.
I agree. Thank you so much, Dr. Burden. Just quickly, my time is winding. Also wanted to ask Dr. Nozel, and the question for you is regarding research and preventative care. Actually, the question I want to ask you about, since I just have a few moments, is about marginalized communities and federal research funding that's helped make significant advances in understanding aging and age-related diseases, and ask you, how should NIH ensure that its aging research includes diverse populations, particularly for historically marginalized communities? And I know that's a longer, we don't have very much time, but whatever you can say to that would be helpful.
It is critical that research is happening in our communities, in my communities that have Black and brown individuals of various backgrounds, ethnicities from around our world, that how they are impacted and what needs to be done to really prevent the heavy cost of care in the future is different because of the dynamics and the communities that we're in. Research into connections with faith-based organizations, connection with communities, and we really see that those are opportunities within communities like mine that aren't being leveraged for research, where we know trust and strength is already in the community, and it's a real place where we could make those benefits to health and outcomes possible.
Thank you so much.
Thank you, Ms. Nozal. Ranking Member Gillibrand, I heard you had a few more follow-ups.
A couple more questions with Dr. Buettner. I really liked your testimony. What I really liked about what you talked about was that you were talking to cities and communities and leaders about much more of a strategic plan for what they could do for the health and well-being of their citizens. And what I really liked about your approach, it was no silver bullet, it wasn't even silver buckshot. It was, you have to do all these things. And you mentioned transportation, making sure people could walk, walkable cities, so they could ride bikes. I would imagine as part of that, you'd want some kind of mass transit or some kind of public transit so an older person could actually get somewhere, because an older person might not be able to walk for a mile or a long distance. Did you talk to them about access to fresh fruits, vegetables, whole foods? Like, if you go to the Bronx today, it's a food desert in some areas where it's just not accessible to get to a grocery store. You might be able to get it to a bodega or a corner store, but you might be charged, I don't know, $2 for an apple. You know, it's so expensive. It's not accessible and affordable. Did you look into those types of barriers as well? Did you make recommendations? Because I have legislation to incentivize to build grocery stores in food deserts so that we can get those quick fruits and vegetables for a lower cost price. And then did you hear my conversation with Dr. Nozal about using the federal benefits that we do have better? You know, we made the change in SNAP. This is important for you because you're just new to the committee. We made the change to SNAP to make it easier to use the SNAP benefit at what do we call them? Like a farm stand, to go into a farm stand and to be able to buy the fruits and vegetables directly from the farmer. Better for farming, better for people. And using maybe the SNAP benefits to get the congregate meals. So instead of eating by yourself in front of a television as an 85-year-old, you actually can go to the senior center and have 2 meals a week that are congregate with community members. Do you have thoughts on that too?
Yes. So we've worked in 70 cities, and I've learned that every community thinks they're different, and in that they're all alike. So what we've done, we have boards of academic advisors, and we've compiled, we call them policy menus in food, built environment, and tobacco. And these menus are evidence-based, and there's usually 30 different policies that have worked elsewhere at creating a healthier eating environment and more physically active community in a place where it's a little bit harder to smoke. So in other words, they've improved health. We measure with Gallup, so it's not just anecdotal. We take a measure at the well-being index metric at the beginning. And then in order for us to come in, the city council and the mayor have to pledge to go through this consensus process. And we go through every one of these menu items, every one of these policies, and we score it for feasibility. Can we get it done in this community in 5 years? And for effectiveness. Do we believe it's effective? So do I believe that taxing sodas will lower the amount of sodas that children will drink? Yes. But to lead with that, you will often be shown the door. But we keep it on the menu so they discuss it. So with each of these areas, we have 30 or so policy items. It's hard to mess with SNAP. You can sometimes get sell the idea of a pilot program, but SNAP, as you know, is a federal program, and it's very hard to.
But we are the federal lawmakers.
Well, we
so
love
when
you.
we are writing the Farm Bill, we could improve that program. We
we're
could
go-
make it better, more accessible, more usable.
Let me take you to Jacksonville, Florida, and I'll show you some opportunities for the SNAP. But the bottom line is, again, trying to come in and tell people what to do doesn't get you far, but showing them how they can be successful within the parameters of what's important in their city, you can get a lot done. And it's a different way of thinking about things. And SNAP, my big criticism is it allows people to buy the same food that's making them sick. So
ideally, you'd like some nutrition dollars to be on education about what's nutritious.
Teaching people how to cook with whole plant-based food.
Yes.
We were talking about this before. We did if you want to know what a healthy 100-year-old ate to live to be 100, you have to know what she was eating as a little girl in middle age and lately. And I worked with Harvard's Walter Willett, and we did a meta-analysis, 155 dietary surveys done in 5 blue zones over the past 100 years.
Yeah.
And without a shadow of a doubt, they're eating mostly whole food, about 90%. Whole grains, garden vegetables, tubers, nuts, and beans. There's no.
So access to those foods is key.
Yes, and showing them how to make it taste delicious.
Correct.
You can't guilt them into eating it.
Right.
They have to want to eat that more than,
Our most successful food banks in New York are the ones that have cooking classes at them.
Bingo.
So they can teach the whole family how to make these vegetables that
Bingo.
may never have seen, they don't know any recipes for, and that's been really effective. Also, along the lines of our earlier conversations, teaching pediatricians and even prenatal doctors, providers, when they get the pregnant woman in to say, when you have your baby, this is the best nutrition for you, this is the best nutrition for your baby, teaching it right away. This is not a hearing on ed reform, but again, if you had the benefit of exercise every day in our schools and nutrition education, you'd be helping the next generation for sure. Well, thank you so much, all of you. This has been an excellent hearing. I think we've had a very lively conversation about ways to improve, and I just appreciate you, Madam Chairwoman, for hosting us, but all of you for the contribution you made to today's discussion.
All right. Thank you again for being here. The committee hearing is adjourned.